When Osstem asked me to give a presentation in Japan, I was hoping that it happened in September because the Rugby World Cup is on this year. But unfortunately, that didn't happen. But nevertheless, I'm very excited. Standing in front of you, I feel very privileged. So thank you for the invitation, Osstem. 감사합니다. New Zealand, we are the proud world champions of Rugby World Cups. I hope we can repeat that for the third time this year. New Zealand, when you think about New Zealand, we have a lot of sheep. As you can see, sheep are blocking the road and causing traffic jams. Sometimes my patients come late to the surgical appointments. That's a joke, by the way. We live in a beautiful city, and hopefully we can hold one of these big conferences in New Zealand in the future. This is my clinic. This is one of my operating rooms where I do my big cases and where I run live surgery courses. So this leads into my topic. I'm showing you 6 examples of the X-rays. They look all different. I want you to focus just on the maxilla for now. We have 6 straight dental implants. We have conventional all-on-4 treatment. We have 5 implants with tilted implants. We have combination of conventional implants and zygoma implants. We also use pterygoid and zygoma implants, and we use zygoma implants. We choose our treatment modality depending on the amount of bone the patients have. Although these X-rays look different, there's one common thing they share. One common thing, that is, the surgery has been done graftless. We use graftless approach. We use graftless approach because we want to limit the surgery to one surgery. We don't want to be performing multiple surgeries to these patients. I don't want to be thinking about bone grafting. I don't want to be worrying about complications of bone grafting. I don't want to be worrying about failure of bone grafting. By engaging these implants to the local bone, we gain tremendous primary stability, and we can immediately load our prosthesis from day one. It doesn't matter what type of implant gets placed, whether it's conventional implants, zygoma implants, pterygoid implants. When you look at it from the restorative perspective, when you look into patient's mouth, everything looks the same. So everything that happens hereafter, the superstructures, everything will be identical. Yes, I'm a surgeon. Surgery fascinates me, but we shouldn't forget that we are doing the treatment to restore the function, the smile, the aesthetics, the confidence and dignity of our patients. But in order to immediately load, we had to convert the denture. This is a problem. After the surgery sometimes takes 2 hours and 4 hours. Patients are in pain, patients are bleeding, patients' lips got stretched, and we are in a position to take an open tray impression, introducing impression material to the surgical wound. We have to modify the denture, creating powders that gets into the surgical wound. And patients are tired, we are all tired, and this is a very physically tiring process. So maybe 2 years ago, our team gathered around and we tried to find a solution to make this better. We wanted to treat our patient without having to take the impression and without having to convert the denture. So we started buying things. Things got a little bit expensive. We buy the facial scan, we buy intraoral scanner, we buy PIC camera, which I'll be talking about soon. We started performing surgery guided, and then my technician had to buy CAD software, 3D printers, and milling machine. So now I wanted to talk about PIC camera a little bit, because It's one of the very important equipment that we use in order to perfect our digital workflow. So PIC camera is an extraoral camera. It uses photogrammetry technique, and by placing PIC flags, or you can call it scan bodies, into the mouth, and it captures the precise implant position by introducing the extraoral camera from outside the mouth. Once the PIC file gets captured, we can export the file in multiple ways. But in our clinic, we export the PIC file so it looks identical to the healing caps that we placed after the surgery. We do that because we want to merge the PIC file with the scans we take, with the healing caps. We want to merge these two structures together. So, why do we use PIC camera? There are many ways to capture the precise location of the implants. We can do traditional open tray impression. We can use the intraoral camera, intraoral scanner, or we can use PIC camera. When you're doing single implant, when you're doing quadrant implantology, impression or intraoral scanner are accurate enough. But when you're expanding that to a full arch, intraoral scanner won't give you the accuracy because intraoral scanner relies on stitching of thousands and thousands of pictures. So it's very inaccurate. I wanted to show you a slide where intraoral scanners, I wanted to show you a slide to prove the intraoral scanner is inaccurate in full mouth implantology. So we got the PIC file on your left photo. Okay. We got the PIC file on the left side, and we bring the PIC file onto the tissue scan. So we are matching the PIC file onto the healing caps. And on the photo on your right side, as you can see, there's a discrepancy between the PIC file and the healing cap. This means that if you use scan body and use an intraoral scan and fabricate your full arch prosthesis this way, the prosthesis won't give you the passive fit. But because we are relying on the PIC camera, we always get the passive fit. It's very passive. Now I want to talk to you about my digital workflow. So there are many ways to perform digital workflow in full arch dentistry. If you go onto the Facebook, if you go onto Instagram, a lot of people talk about a lot of different technology. In our clinic, my technicians, our restorative dentists, we rely on these 4 factors. Number 1, we want to gather as much data as possible pre-surgery when patient is not in pain, when patient is comfortable, and when everything is under control. We also want to establish occlusion before the surgery to limit what we have to do after the surgery. So following the surgery, we just have to collect how the tissue look like and where the implants are. And the most important thing at the end is the merging, to be able to merge all these scans so we can fabricate our temporary prosthesis. So pre-surgical data collection. So we want to collect the information about their tissue and teeth if they have any teeth. And we want to get the occlusal relationship. And it's crucial that we contain the landmarks in our pre-surgical data collection so we can merge or we can relate the post-surgery data to the pre-surgical data. After the surgery, we wanted to capture how the tissue looked like after the surgery. I wanted to capture the precise implant position. Also, I wanted to contain the landmark to merge the pre-surgical scan to the post-surgical scan. So when we have the pre-surgical scan and post-surgical scan, and when we merge them together, we have the post-surgical tissue we have the implant position, we have inter-arch relationship or occlusion, so we can make our temporary prosthesis. But in order to merge, we need to think about the landmarks. Landmarks need to look the same pre-surgery and post-surgery. These can be soft tissue, these can be hard tissue, these can be foreign objects that we artificially place. This is where maxilla and mandible differs a lot. So in the maxilla, we have reliable soft tissue landmarks, maxillary tuberosity, we have rugae, and we have incisive papilla. When we choose to use these landmarks before the surgery, it's important as a surgeon not to cut these areas, not to make any incision in these areas, not to place any implant in this area. In the mandible, we don't have any reliable landmarks, any soft tissue landmarks. So if patients are dentate, we can leave a couple of teeth behind. We extract all the teeth, apart from 2 or 3 teeth. We place 4 implants, and we keep them till at the end of the surgery so we can use them as a reference. Or if the patient is edentulous, or if we have to take all the teeth out, we introduce mini implants before the surgery. So mini implants themselves will act as landmark. So I'll show you a case. Maybe this can be a little bit confusing, but hopefully by showing you the case, we can get you to understand a little bit better about the digital workflow. Got Mr. Ian. He's edentulous. He wears complete dentures. He hates complete dentures, and he wants a fixed solution. That's his denture. I look at him, and immediately I see I don't like his current denture because he doesn't display much of his maxillary teeth. And I wanted to change this, and I wanted to change this before the surgery. So I take several scans. I'm going to do intraoral scanning of the mucosa. I'm going to reline his existing denture, and I'm going to 3D scan his existing denture. And then I'm going to obtain his occlusion. After that, I want to perform facial scan. First facial scan is the facial scan of the patient's face. Second facial scan is the facial scan. I use the bite plate, and I put it up against his upper denture. This is just like a face bar, so we know exactly where his upper teeth are sitting in relation to his facial structure. So I send all the scans to my technician, and my technician receives the data. In the middle, there's a 3D scan of his existing denture, and on the sides, we've got a soft tissue scan, and we're going to merge these two together. So once the scans are merged, and when we take the denture scan out of the equation, we have the soft tissue orientated into its inter-arch relationship. We bring it onto the facial scan, we take the denture out, and my technician gives me a new appliance. So this is the new appliance. It doesn't have to look pretty. All I want to do is to check the teeth position and the occlusion. So this is the teeth clinically. I'm happy with how much his teeth are showing in the maxilla. And I'm happy with the occlusion, I'm happy with the midline, I'm happy with the occlusal vertical dimension, so we can move on. We can move on, and I'm going to scan this new appliance again. So reline the new appliance, 3D scan it, and I want to get the bite. This is the crucial bite This is very important bite because we're going to rely on this bite to fabricate our immediate temporary prosthesis. Before I move on to my surgery, I want to do one more step because I want to digitally plan my implant surgery. So this process is widely known as dual scanning protocol. So I place some radio-opaque marker onto the appliance, and I CT scan the appliance. And I place the appliance into the patient's mouth, and I CT scan the patient. I upload the CT scan onto 3Shape software, merge the appliance scan and patient scan together, digitally plan my implant case, and my technician gives me surgical guide. So let's look at the surgery. This is the Osstem 1 guide, sleeveless guide. The guide is being handheld. I'm going to use the tissue punch, just remove the mucosa. I'm just removing the mucosa. I'm going to perform the surgery flabless. No alveolectomy, just flabless, fully guided surgery. Now I wanted to keep the guide stable using the bite jig. And I'm placing anchor pins to stabilize the guide. I'm sure you guys have seen a lot of this today, guided osteotomy. So this is the second drill, 2.2. .5. And the final drill I'm using, I'm not going to go into the full depth. I'm going to under-prepare because getting the primary stability of these implants are crucial for immediate loading. So the implant gets placed. Second implant. I'm going to adjust its depth, final manipulation. And I'm checking the torque, I'm very happy, 30 to 35 Newton centimeters. We can immediately load. Distal implant, this is final drill. I'm under preparing it again. This implant is tilted. Very easy surgery, fully guided full arch implant surgery. And this is the last implant on the left hand side, also tilted to about 30-degree angulation. Now I take the guide out. Apart from a little bit of bleeding, it's a very clean surgery. Now this is the Osstem bone profiler. I placed this little guide which is going to protect my fixture. And then I'm going to use this drill to remove all unnecessary bony ledges around the fixture. So my multi-unit abutment can fully sit down. So this is the straight multi-unit abutment. And once they are in, I always check with my stent, not the surgical guide, but separate stent, where the screw access hole will be coming out. I'm very happy it's coming out at the lateral incisor position, palatal to the teeth. Posteriorly, I use Osstem angled, 17-degree angled multi-unit abutment to compensate for the tilting of the implant fixture. So this is the PIC file that gets placed onto the multi-unit abutment. We place 4 of them. And this is the real-time capturing of the implant positions. no impression material, no impression copings, digitally taken, a precise location of the implants. When the green bar hits the top, the impression is completed. So that's the pick file. As I said, those pick files will match exactly to the shape of this healing cap. In the mandible, because I had to do some alveolectomy, I've decided to use a pilot guide. But this is the mini implant. This mini implant has nothing to do with holding the prosthesis, but these are being placed to act as a landmark. Once the mini implants are in, because it's very hard to scan the metal surface, I use the impression coping, plastic impression copings onto them, and I scan it. You can regard this as a pre-surgical scan because I haven't placed any implant yet. Now this is just a pilot guide. It will give me a rough idea where the implant should go. Rest of the surgery will be done freehand. So I'm raising a flap to do alveolectomy. In the mandible, it's crucial to expose the mental nerve. So there's the mental nerve. And I plan the surgery so that I have to do about 5 millimeters of bone reduction. 5 millimeters of bone reduction to give enough restorative space so my prosthesis doesn't break. Many ways to do alveolectomy, but I chose to do it this way for this surgery. So I'm going to remove the bone in one piece. It comes out in one piece, giving me the flat bony surface so I can place my implants, and I'm going to do the surgery freehand from here onwards. So in the mandible, bone is very dense, so we can easily achieve the primary stability we want. So distally, I wanted to stay in front of the mental nerve so that the patient doesn't get numb. Again, the distal implants are tilted to about 30-degree angulation. Because my anterior implants were quite lingually placed, I brought them forward with multi-unit abutment using a 17-degree multi-unit abutment. This is the last implant. Again tilted, staying in front of the mental nerve. I also placed Osstem TSⅢ implants. And the mandible bone is so dense, I don't even bother checking the torque. I just know it's stable. I'm going to finish my surgery by placing a 17-degree multi-unit abutment again. Again, place 4 pick flags onto the implants. By the time I got so tired, I get my assistant to take this capture. Whether I do it, whether my assistant does it, once it's captured, the files are identical. So there is no operator sensitivity. So that's the impression done. And that's the after the surgery. And one more step I have to do after the surgery is the intraoral scan, the post-surgery soft tissue, and then I take the mini implant out. Now this is where it gets a little bit confusing. I send all the scans off to my technician, and my technician will magically bring all these scans into one unit and will give me back the temporary prosthesis. Let's focus on the pre-surgery scans. On your left-hand side, we've got the scan of the appliance and the soft tissue scan. We're going to merge them together. We're going to bring the upper mucosal scan onto the fitting surface of the appliance. In the mandible, it's different because I did an additional scan with mini implants. So I'm going to bring that mini implant scan onto the pre-surgical mucosa. And I'm going to bring that to the fitting surface of the lower appliance. Now we're going to focus on the post-surgery scans. I'm going to bring the PIC scan onto the post-surgery tissue scan. Do exactly the same for the lower. As a final step, I'm going to bring these 3 scans into one unit. So this is the photo of all the scans merged together. And then we remove everything except for the post-surgical scans, which contains the mucosal post-surgery tissue information, implant positions, and inter-arch relationship. And my technician designs a temporary prosthesis and mills it for me in PMMA. I'm happy with my maxilla. It's perfect positioning. In the mandible, for a temporary prosthesis, I removed the first molar because I'm getting a bit of distal cantilever, but I was limited by the relatively anteriorly positioned mental foramen. So this is the next day. Clean looking area. And the temporary prosthesis gets fixed. Feels very passive. I'm going to do one screw test. Just loosely tighten up one screw and check the passivity, and it feels really passive, and screw gets inserted in very easily. So for now, I'm just loosely tightening them, and once all 4 screws are in, I'm going to torque it down to 15 Newton centimeters. This is the lower. I do exactly the same for the lower. I won't be showing you every steps for the lower. So this is the occlusion and adjusted occlusion, all digitally fabricated. And this is the post-op X-ray, conventional all-on-4 treatment pattern. Bridges are fitting passively. You're not gonna get any bridge that's fitting more passive than that. This is Mr. Ian before and after. This is him day 1 after the surgery. He gives me big thumbs up after the surgery. This is why I wake up in the morning to turn up to work. This keeps me going to improve and get myself better as I progress through my career. I want to thank my team as well, my kind team, my supportive team. I've got a, hold on. I can see CJ there. He's my technician. He's the best digital dental technician. So thank you. 30 minutes was a very short time for me to explain all our workflow. We treat these cases week in, week out. And if you want to find a little bit more, you can email me or you can like my Facebook page. Thank you very much.